Okay, today we're going to be starting Chapter 4, and I'm not going to lecture thoroughly on Chapter 4 since hopefully tomorrow we'll be able to touch a little bit more on it, but I do hope that you find this helpful. Let's start on your PowerPoint and in your book on page 60, and we're going to talk about processing insurance claims. We've talked about the CMS 1500 claim. That is the main form. It's adopted by Medicare early 90s, I believe, and now everybody uses it to bill insurance companies. So this is used to report professional and technical services. So information from the super bill in the patient record or the medical chart is then transferred to the CMS 1500. So basically, when the patient checks out, usually when you go to the doctor, you have little check marks on what was done. That super bill and your note and labs from that day is used to code what was done, including diagnosis and procedure codes. Let's see. Let's talk about accepting assignment. That's one of your key terms, to accept assignment. And you've seen this term on the Moss studies. Accept assignment when the patient does this is saying that they basically accept the charges that the physician will do. And it also means that the insurance will agree to pay whatever, or the practice or physician will agree to pay whatever the insurance pays. And then an out-of-pocket payment is something that some health insurance plans may require, and usually if it's out of pocket, it's like $1,000 to $2,000 at the maximum. So that's what out of pocket payment is. Let's see. So let's look at the next slide. It says going on more about the CMS 1500. This requires responses pertaining to patient's condition and, if related to employment, auto, or any other accident, additional insurance coverage, or use of an outside laboratory, and whether or not the provider accepts assignment, which we just talked about. And if you look on page 61 in your textbook, this is an example of a current CMS 1500. And we're not going to go into great detail about this because we are going to have a whole chapter on how to fill out CMS 1500 form. So we're not going to really spend too much time on this. Let's see. If you look at another slide, it talks about that the patient is responsible for any co-insurance and co-payment amounts, and we've talked about those terms in the previous chapters. And so to clear the physician's office and to say that they've accepted assignment, they have to put signature on file in all caps, or for short, a lot of times we put SOF as an abbreviation. And so because if you'll notice back on that figure of the form in blocks 12 and 13, it says patient signed and the date. So instead of having the patient to come back and sign the form, we just put signature on file in all caps, or SOF in all caps, and that covers us. And usually you have to do it in both blanks, but we'll get into more details on that later. So then after that, the claim is proofread, double check, make sure everything's good, and then any supporting documentation that needs to be attached is attached, and then usually it's sent on from there. Let's look at the assignment of benefits. This is the patient or insured authorizes the payer to reimburse the provider directly. So that's what assignment of benefits is. I may have skipped over that term. And then also what you have to realize with insurance stuff is pre-existing conditions, and that is like one of your terms on page 62. It's in italics. But a lot of insurances have a pre-existing condition clause. So basically, let's say I have high cholesterol and, I changed jobs and changed insurances. A lot of times it'll say that they may not cover any cholesterol issues, whether it be medications or physician visits, laboratory, etc., for a period of a few months or never. And usually now they've got it to where it's pretty strict, and insurances now really do have to cover pre-existing, because everybody in most cases has pre-existing conditions. So that's what a pre-existing conditions clause. So it determines the patient's eligibility for coverage. If the patient was treated for a medical condition prior to the effective date of the insurance, there is always a pre-existing clause, and so you have to kind of look over that and see what's going to be covered. So maybe when you change insurances, you may have gone to the doctor and come back, gotten your explanation of benefits, and realized they didn't pay for anything, or maybe they only paid for, something else that wasn't related. Then you know that something's going on with a pre-existing condition. But usually, at the most, it may last a few months now. It used to be where they didn't have to pay it at all. Going on to accounts receivable management on page 62. This assists providers in the collection of reimbursement for services rendered. So basically, when the patient gets there, you have to verify their eligibility. Okay, you may have to do patient and family counseling about insurance and payments, especially if they're out of pocket, a big deal. You may have to counsel with them and do a payment plan or something like that. And then you may have to provide assistance with obtaining community resources. For instance, if the insurance doesn't want to provide a wheelchair for a disabled patient, you may have to, try to get a larger discount through a community resource, or possibly even get the patient the resource for free. So it's really important that you know a lot of the community resources around the area that you work. And I believe it's in another class that you'll cover how to find community resources. But if you look on page 62, you see an insurance verification form. Nowadays, usually you don't have to do a handwritten form. You do it online, and you can actually do that on Moss as well. And we're going to do that in class. We'll practice that in class the next time we meet. And you'll actually have a competency on that. And in your workbook, you have to fill out verification forms. So basically, you for your competency, you're going to have to hand fill out a verification form. And then I want you to do one in Moss so you know exactly what to do. And that's what you have to do with every patient that comes in. You have to verify their insurance coverage, because it could change. They may have been in yesterday and then all of a sudden it changed. So that's what the verification form is, and that will be a competency that we'll probably take with your exam. And we're going to practice this in class as well. Let's go on. Let's talk about completing the CMS 1500 form on page 63 for a little bit. Actually, never mind. I'm sorry. We already talked about the signature on file. So let's go on to managing new patients at the bottom of page 63. You have to know with new patients, the new patients should always get a copy of your office policies, and every year office policies should be reviewed by the administrative staff, or the practice managers, physicians. And every year when the patient comes in, if there was any changes to the policy, which there usually is, you have to get the patient to sign a new policy. There may be a new policy about co-payments, appointment rescheduling, no-shows. There's all kind of policies. So any of that kind of stuff should be posted at the receptionist desk, and it should be told to the patient when they come in. Let's see. And then after they sign policies, then you can go ahead and register the patient like you usually do. Then the patient has to fill out their patient registration form, and then of course from there you can go into your electronic health records or medical records and type in all of their demographic information. Then with their insurance card, you have to print a copy of the front and the back. Make sure you do the front and the back, because the back usually has co-payment information, contact information like address, phone number, email, fax, all that good stuff. So that's why we need a front and back copy of the insurance card. And usually we like to try to get it on the front of just one page. And then you want to file it in the patient's record from that. And that kind of list there on page 64, it talks about step 1, registering the new patient. So it tells you basically everything to get, and most of you know that, I'm sure, from doing, going to your own office visits with physicians. The guarantor is a key term there, and that's the person that's responsible for paying the charges. And that doesn't mean, if the guarantor is the policy holder, okay? So make sure you remember that. The guarantor is the policy holder. So you may handle the finances, but the guarantor is the policy holder, and ultimately they are responsible since it's, they're the primary insurance holder. Let's see. Let's talk about PAR, a participating provider. I think we've talked about this before, but a participating provider is basically one that your insurance or the patient's insurance will cover. And then you have non-participating provider or non-PAR, and that's where, it may be out of network or they don't participate with that insurance. So you may be, out of pocket for the entire visit or a portion of the visit. Let's look at page 65, and we are going to do some examples of these because I know you have these in your workbook as well. Let's see, example 1, you have Dr. Smith is a participating provider for the ABC Health Insurance Plan. Kathy Barton is treated by Dr. Smith in the office, for which a $50 fee is charged. So the PAR provider fee is $50. The contracted rate is maybe $40. That may be like 80%. Remember we talked about how insurance will pay 80 and the patient pays 20. So they say they'll pay a certain percentage, of your fee. So they say they're going to pay $50. Then they're going to pay 80% of that $50, and that may be $40. So then your copayment would be $10, which is the 20%. It may be 10. Yeah, it may be 20% in this case. So the whole insurance payment is actually $30, and then the write-off amount is actually $10. I hope that makes sense. And the second example, he's a non-participating provider, and this patient's treated by Dr. Jones, and there's a $50 charge. So a non-participating provider fee is $50. The usual and customary rate for non-participating providers for this patient's insurance is $45, and then the patient will be responsible for $8. So the insurance total payment is actually $37, and then $37, and then of course the provider can bill the patient the extra $5. So we're going to talk about that, and the way that we'll do it is going to be similar, but maybe a little bit different and maybe a little easier for you to understand. Then it says step 2, you have the patient complete a registration form, which we've talked about. Step 3, photocopy the front and back of the insurance card. If you look at figure 4.2, that shows you what a typical Medicare card looks like, but it doesn't show you the back. So again, you need to remember to do the back. Step 4, you're going to confirm the patient's insurance by verifying. Okay. Step 5, you're going to enter all their information in the software. If the patient has like a primary insurance and a secondary insurance, then those two insurances will have to have a coordination of benefits. And that means basically they come together and decide, okay, well, your primary is going to pay 60% of whatever charge the visit is, and your secondary will pay the remainder 40% of whatever the charge is. So that's what coordination of benefits is, when two or more insurance companies come together and they've determined, who's going to pay primary, who's going to pay secondary, tertiary, etc., etc. Let's see. Let's look at page 68. You have an example there, and we won't talk about that, but it kind of tells you how they determine primary and secondary. And we're going to talk about the terms used for this. So the first term is primary insurance, and that's the person's first insurance that they will use, okay? So it's going to be the first responsible plan that the patient's going to have. If it's a child of divorced parents, then whoever has primary custody will be the primary card holder, or will be the primary insurance carrier, okay? If the child lives with both parents, whoever has the insurance through, let's say your husband is working and you use his insurance, then he would be the primary card holder. Okay, and it gives you some examples there. Then we have the birthday rule as well. The birthday rule, let's say, the birthday rule, it states that the policyholder whose birth month and day occurs earlier in the calendar year holds the primary policy for dependent children. So let's say I have a primary policy at my work and my husband has a primary policy. But then we have a child, then whoever's birth date comes earlier in the year would be considered the primary policyholder for that child. So that's what the birthday rule is. Then we have the gender rule, and it says some self-funded healthcare plans use the gender rule, which state that the father's plan is always primary. So every insurance may be a little bit different, but fortunately, a lot of this is taken care of electronically. When we do our verifying, it's good to go, and we don't really have to worry about anything. So step 6 is we're going to create a new patient record. Step 7 is we're going to generate the patient's encounter form, and that would be like the list of charges that you may see the doctor writing on. So the encounter form is the financial record source document used by healthcare providers and other personnel to record treated diagnoses and services/procedures that were done. Another word for encounter form is super bill. Okay, super bill is the same thing. And in the hospital, a super bill is not called a super bill, it's called a charge master. And basically, every time the patient, physician fees are charged separately, but let's say a patient needs a catheter. So on the catheter, there's usually a yellow sticker that the nurse peels off and puts on a charge master. And at the end of every day, the unit secretary will use the charge master and enter in all the charges for the patient. So in the hospital, it's called a charge master. Office, it's called an encounter form or super bill. Make sure you remember that. Let's see. Let's talk about managing established patients. With established patients, the first step is you want to schedule a return appointment when they check out or when the patient contacts the office. And it's best to always schedule it while they're there because, patients usually forget because we all live busy lives. So the best way to do it to confirm that they actually have a visit is that you schedule them while they're there at their previous appointment. Okay? Let's see. If you look at the example below, it shows you a follow-up visit, and so the receptionist or whoever, even the MA or whoever's back there can say, okay, he needs to follow up if his symptoms get worse. So that would be one that we wouldn't need to schedule, but we'd want to make sure we tell the patient that as well. Okay? If it says they have to follow up in 2 weeks, then we know we need to schedule them a 2-week visit. So if you look on page 70, that's an example of just one encounter form, but they can all look different. Step 2, you want to verify the patient's registration information, make sure nothing has changed. So you always want to say, is there anything changed? Have them change it, manually, and then you retype it in. And then step 3, you want to collect the copayment from the patient, and it usually tells you now on the card what the copayment is, which is very convenient. Step 4 is to create an encounter form, and again, this is for established patients. Okay. And look at the very top of page 71 at the managed care alert. Approximately 1 week prior to an appointment with a specialist for non-emergency services, there should always be a pre-authorization done from either the office that referred them to a specialist, or the specialist office should do the pre-authorization or the referral. So make sure you do that. And they'll need, of course, you'll need to send all of their records that the physician may need, etc., etc. All right, let's go on to managing office insurance finances, the bottom of page 71. So these are for new and established patients. Step one is you want to assign CPT codes. Occasionally, you may have a HCPCS code, but it's very rare. So you want to assign those to the encounter form, okay, after the patient, while they're there or after they leave. Make sure that everything listed is going to cover and link to the diagnosis, and we're going to talk about that later and do some practice with that. Then step two, after all the codes are done, then you want to enter charges and services that are performed on the encounter form. Step three, you're going to post all charges in your electronic health record system. And then what we have, before electronic records came out, we had individual ledger cards, and they kind of look like that on page 72. They were little manila covered, hard cards that we wrote every financial interaction on. So, but now it's pretty much done electronically. So you can post charges and say print ledger card to, put in their financial record, and it'll do it for you without having to, enter it in 1,000 times. So the patient ledger is also known as the patient account record, because it shows, if they paid a co-payment, if their insurance paid, then we'll go in and post a payment from the insurance and all that. So that's what I told you guys to practice on before we come back to class on MOS, is posting payments, or posting charges and all that good stuff onto MOS. Then let's see, look at the bottom, middle of page 73. We have the manual daily accounts receivable journal. This is also called a day sheet. A day sheet is basically everything that happened that day, whether you received some insurance, whether you received a copay, insurance payment, whatever happened, it goes on the day sheet. And these day sheets are good for financial records and accounts receivable, because they can go and chart and see how much money they made each day, and determine if it's lowered, or if it's, at an increase and all that good stuff. So that's called a day sheet. And again, this used to be done manually, and some offices still do manually and electronic. And if it is a day sheet, they'll usually put it on this pegboard system, and where they can keep up with it, and you can attach like a super bill over it and receipts. And it's also called a write at once system, because you can write everything out and it transfers all the way down to the very bottom of the day sheet. So the day sheet again can be filed separately, and it can keep up with your income for the day. So the step 4 is to bill the insurance policy, and then bill the patient for any co-insurance amount. Let's see. You can look at a little hint at the bottom of page 73. To save the expense of mailing invoices, you could ask patients to pay their portion as they depart the office if you want to. However, this is not usually done. I only know a couple of offices that may do this, but at the time when you verify their insurance at each visit, it will tell you what their co-insurance is. So if they're responsible for 20%, and then at the end the medical assistant or the physician has already done all the coding for you and the charges, and you know exactly how much they're going to be responsible for, you can go ahead and ask for it then, and that will save you an expense from doing the invoice. Step 5 is to post payments to the patient's record. Okay, so if you need to also make sure that you post how it was paid. Was it paid by cash? Was it paid by credit card? Did the insurance send a check in? Did the patient write a check? So you need to write how it was paid. Step 6 is completing the insurance claim form. And then, I'm sorry, the claim form, completing the insurance claim. And basically you have like a registry. And again, this is done electronically. You can go in through the day and type in the date range of all the claim forms you want to see and their status. And you can hit print, and it prints a nice pretty report for you. And you can also do that on the individual patient as well. So it's pretty much done electronically now, which is very nice. Step 7, you want to attach all your documentation to the claim. Step 8, obtain the provider's signature on the claim. A lot of times they have a signature stamp, so you don't have to go and bother the physician, 1,000 times a day. Step 9, file a copy of the claim and copies of the attachments and the insurance files, okay? And you should have separate insurance files. You should have some for active or open, meaning that you've sent it and you're waiting on a response. For inactive, meaning you haven't heard anything in a while, or like a cold case basically. So you can have several different files for that depending on the office policy. Step 10, you want to log completed claims in the insurance registry, and again, that's pretty much done online. When the computer sees that, or the software sees that you've posted everything, all the charges, and then you've posted payments that covers everything, it'll clear it out and post it on a report that you can print out. And then step 11, you want to mail or electronically send the claim to the third-party payer. So, going on to the insurance claim life cycle. The life cycle consists of 4 stages. You have the claim submission and the electronic data interchange, where you submit the claim and it goes through cyberspace. The step 2 is claims processing, and that's when the insurance company processes the claim and decides what they're going to pay. Step 3 is the claims adjudication, and this is basically where they will figure out who's paying what as far as primary or secondary, what the patient owes. And then step 4 is the payment. And adjudication also includes the insurance specialist looking up to make sure that they're going to cover certain services and that they have the right diagnoses as well. Let's see. So some pros and cons are of doing electronic claim submission. First of all, it's going to reduce your payment turnaround time because you're not having to manually fill everything out and send it in, and then they have to send a response back manually. So, you can get a pretty good turnaround time. It reduces claim submission error rates because, as you'll find out in a few more chapters, you can make a lot of errors doing claim forms because they are very specific as to what they want. Audit by the clearinghouse results in clean claims. So the clearinghouse clean claims, it contains all the required data elements needed to process and pay the claim. So everything's nice and neat when it's done electronically. Look at page 75. Let's talk about some of these. We've already talked about claim submission. Let's look at a clearinghouse. A clearinghouse is a public or private entity that processes or facilitates the processing of non-standard data elements, like a paper claim, into standard data elements. So that would be like an electronic claim. So you do your paper claim and then they do electronically. That's basically what a clearinghouse is. Look at a value-added network, or a VAN. This is a clearinghouse that involves value-added vendors like banks, while they're processing the claims. So basically what they can do is they can direct deposit the payment into your bank instead of sending you a check. So it's really convenient. Let's see. Let me see what I want to talk about. Let's talk about claim attachments. No, before we go there, let's flip to page 76. And let's talk about HIPAA for a minute, the bottom of page 76. Everybody knows what HIPAA is, and so basically, for HIPAA is used in all of these transactions to determine your eligibility for a healthcare plan. It's going to cover you for that. Enrollment and disenrollment, the first report of injury. I won't name all of them, but basically, HIPAA, helps and controls your privacy when all of that following list is done. Covered entities on page 77. That's a key term. Covered entities include all private sector, whether it be hospitals, physicians, other places that the insurance will cover. Let's see. Yeah, so that's what a covered entity is. If the provider's office uses paper claims to bill, then the office usually contracts with the healthcare clearinghouse to conduct the standard electronic transactions. And now, with the EHRs being mandatory, I doubt they have to do this. However, there may be some offices that still pay that clearinghouse to transfer it to electronic format for them. But I'm just not sure because I haven't really been out enough to see how they're doing billing since October when it became mandatory. So let's talk about, we've kind of already talked about a clean claim. That's basically where, it's nice and neat, everything's there, you don't have any errors. That's what a clean claim is. Alright, now let's go to claim attachments, bottom of page 78. This can be anything. It can be, the patient's visit, their lab work, anything like that that's going to serve as extra information for your claim and the patient's visit to be paid. It gives you some examples there you can look at. How to avoid resubmitting claims is just to do it correctly the first time. So a lot of times if the patient isn't covered, you're going to have delayed claims. They may send them back 1,000 times, but if you follow the rules exactly and do as they tell you to, then you will usually not have to worry about having to resubmit claims. We already talked about coordination of benefits, but you do have that term again on page 79. So then let's go to claims processing. This involves sorting claims upon submission to collect and verify information. So this is going to be the insurance responsibility. So if you go to Aetna, then somebody at Aetna, you have insurance verification specialists or whatever they call them, and they'll look at the claim and verify that everything links together, everything was done correctly. So that's what claim processing is. And then claim adjudication is basically the same thing. They want to make sure that the claim hasn't been duplicated. They want to make sure that everything links and is on there. Everything, every other documentation or lab result needed is there, and all of that kind of good stuff. So that's what claims adjudication is. And so let's look at page 82, the very top. Let's talk about a non-covered benefit. A non-covered benefit is basically what it says. Any procedure or service reported on the claim that is not covered. So when that happens, usually the office has to write it off if it was their mistake, or the patient pays out of pocket. And then procedures and services provided to a patient without proper authorization is called an unauthorized service. So sometimes this can hold up payment of claims and cause the patient to pay all of it out of pocket as well. So that's why we should do it, just right and link it correctly. And we're going to do some linking exercises the next time we meet, so you can really make sure that you've got it, down pat. Let's talk about allowed charges on the bottom of page 82. A determination is made as to allowed charges, and this is the maximum amount the payer will allow for each procedure. So the allowed amount for, let's say, a new patient office visit maybe $90. Okay, but that's the allowed amount that they give. The office may charge $130, but since they've got a contract with whatever insurance company, they've agreed to accept that $90. So then what happens is the insurance pays their portion of the $90, and then the patient pays the other percentage of it, like the co-insurance. And then, of course, if you have deductibles, which usually every new year you're going to have a deductible depending on the insurance, and you have to pay out of pocket until your deductible is met. So unfortunately, that is one thing, where insurance companies can save a little bit of money. Co-insurance we've already talked about there, but you can read over that. And then on page 83, you have an example there, and this is showing the claims adjudication process, so you can look at that example on page 83 in the middle. So let's talk about payment of claims at the bottom of page 83. Payment of claims, when you do that, you get what's called, the physician's office will get what's called remittance advice. And this is basically showing what the insurance is going to pay, okay? Now, if your insurance person that's getting this remittance advice, if they're good, and after some experience, they will know what percentages each insurance likes to pay and the different group plans like to pay, and then they can do their own calculations to make sure that they are paying what they're supposed to be paying. So that's how that's done. And then once the remittance advice is sent to the insurance to the physician's office, the patient in turn gets what we call explanation of benefits, which is basically the same thing. It's not a bill, but it just shows you what the physician's office charged, what they paid, and what they did not pay. Okay. Now, a lot of times that is not, what they did not pay may not be billed to you. That may be written off. And other times it may be billed to you. It just depends on policy. If you look on page 84, you see an example of remittance advice, an example of an explanation of benefits. And we will go over that because I know you have to answer some questions as part of your homework and your workbook for these. So we will kind of go over these and kind of learn as we go how to interpret them. And as we go furthermore into coding and billing, you'll be able to see more how to interpret it. You also have very detailed instructions. It's very good on page 85, and you can look at that in that purple box. Okay, let's go on to page 86 on the state prompt payment laws and regulations, and every state may be a little bit different. Let me see. Let's look at that. The Prompt Payment Act was in 1982, and it required federal agencies to pay their bills on time or risk paying penalty fees if the payments are late. So now insurance companies can't really waste time about sending in their payment. They've got, I think 28 days to submit a remittance advice to the office and submit the explanation of benefits to the patient. So that's a very good law that came into play, because before it was taking a very long time to get a payment back from the insurance company. Maintaining insurance claim files on page 87. Okay, CMS requires providers to retain copies of any government insurance claims and copies of all attachments filed by the provider for 6 years minimum. A lot of places will keep them indefinitely, and they'll purge them after so many years, after they've been closed for so many years, and we can purge those, but some people will send them to to be incinerated, and some will keep them lifelong. But now the normal state laws is about 6 years, but that could vary from state to state. Then I did briefly mention about the different types of claims, so let's look at those. We have the open claims, and so we can organize these by month in the insurance company, And basically these are ones that have been submitted and we haven't received payment or they're not completed. So that's open claim. And I've seen the best way to do this is those big accordion folder binder type things to do these. Then we have closed claims, and these are filed according to year and the insurance company, and include those for which all processing has been done, everybody's gotten paid, everything's completed. And then we have remittance advice files. Every remittance advice that the physician's office gets must be kept. Now I know a lot of people, and myself included, once I look at the explanation of benefits, I'll trash it if I don't have any questions. But really, a lot of times patients should keep that explanation of benefits, because you never know when a physician's office or hospital may make a mistake and come back, and then you don't really have any proof without doing a lot of digging that everything was taken care of. So those are your and then 4, we have unassigned claims, and basically these are organized by year, and they're generated by providers that do not accept assignments. So if it's out of network or they don't take insurance, this type of insurance, we can put them in the unassigned claim category. So those are your 4 different types of claim files. Alright, let's go on to talking about tracking unpaid claims. And you do have to track them. You don't want to just let them sit there in your file for 3 months and nothing's come back. You want to look through it. Your policy may be once a week, once every couple of days. You have to look through and make sure that it's been completed. That's why it's also good to keep a log. That way you can say, okay, I got a payment from this person, let me check them off, they're good to go. And then you can see a whole list of who has not been paid, who has not paid you yet. So you can read about that, and that's tracking unpaid claims. If you do have the remittance advice, if it's not paid for, it'll give you a code that shows you why it wasn't paid. And then there's a little legend, usually at the bottom or on the back, that tells you what each code is for. So it's pretty easy to interpret after you get used to doing it. Let's look at remittance advice reconciliation on page 88. Alright, so remittance advice reconciliation. Basically, when the payment and the remittance advice has been sent, we want to look at the claim, review it, make sure it's right, and then we post the payments. If there's anything not right, we need to take care of it right then. And then if everything's correct, it can then be moved to the closed claim files that you have. And then if there's an appeal, because a lot of times we do have to appeal, and sometimes it's the physician's office that appeals, and sometimes it's the patient that appeals. So appeals, usually you have to have a written or typed letter saying what the reason is. You have to have all your documentation, your remittance advice or your explanation of benefits, receipts of copayment, etc., etc. And so an appeal is basically what that is. And you're appealing, like you're disagreeing. You want to say why you disagree, what your account number is, your doctor. There's a lengthy list of information that the patient has to have. Appealing denied claims. If it was denied, you have to, usually it's because of one of these reasons. It's either a pre-existing condition, that they may have a pre-existing condition clause, so you have to look over that. It could be, they could say that the procedure or service wasn't medically necessary, and that's when you can appeal by digging through the chart and seeing, okay, well maybe, they did have high blood sugar this time, so maybe if I go back and say a history of high blood sugar, maybe then they'll cover this certain blood test that I want to do. So a lot of times that's what we have to do when we do appeals. Non-covered benefit, maybe it wasn't a pre-authorized procedure, maybe you didn't get a referral, so that's what a non-covered benefit is. Termination of coverage, maybe the patient, got fired from their job and their coverage terminated. Maybe they changed plans at the end of the year and now it's a new year. And then failure to obtain pre-authorization, that kind of falls in the other category as well. Then you may have an out-of-network provider that was used that may not pay quite as much. A lower level of care, it could have been provided. A lot of physicians get this because they will say, well, I want to charge this because I spent a lot of time with them, or the doctor may have spent a lot of time studying their case, but they only spent like 20 minutes with the patient, but they say they spent 60 minutes. And according to the documentation, that didn't happen. So basically, you have to tell your provider, if you want to charge this, then it's got to be in the documentation. You have to have certain guidelines. And when we talk about evaluation management codes, I'll tell you about what guidelines they look for. Incorrect codes, or they may be incorrectly linked on the claim form, and we'll talk about that later. A bundled service or a global period service is not eligible for separate payment. A bundled service is the same thing as a global service, and a global service is like a big procedure, and everything is grouped inside of it. Let's say like surgery. Let's say I had an appendectomy. Instead of coding for appendectomy, a pre-surgery consult, a post-op consult, anesthesia, everything is grouped into appendectomy, and it's a global bundled one code. So the person that's billing doesn't have a zillion different charges to put in. So that's what that is. Claim contained incomplete information, or another insurance plan is primary. That can happen as well. So those are some of the reasons why people appeal claims and why claims are denied. Alright, going on to credit and collections. On page 91. We'll talk about this very, very shortly. We're not going to talk about it for in detail. But with credit and collections, you have to review delinquent claims and talk about ways that you can prevent delinquent claims. And it could be the patient could be delinquent as well. You want to verify health insurance cards. That's why, and that will help you avoid having to take someone to collections. Determine each patient's coverage right when they get there, and then you want to submit a clean claim with the proper documentation. So those are some reasons to keep you out of collections. Let's see. You want to contact the payer to verify they received the claim. If you haven't heard anything, maybe contact Blue Cross Blue Shield, Evergreen, whoever it is, and say, this is such and such. I'm trying to call in regards to this patient, their date of birth, blah, 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 the physician is, etc., etc. And then they can tell you, they never received it or what the holdup is. You want to review the records to determine if the claim is paid, denied, or pending. Sometimes they can slip through the cracks. And you want to submit any supporting documents as well, and that can help you from, having to be behind, basically. Let's look at page 91. Accounts receivable is a key term there, and that's basically the amount that's owed to a business. So the insurance will pay the physician's office or the hospital, whatever it is, a payment, and the accounts receivable department is the one that handles it. Alright, then you have several different acts here. You have the Consumer or the Truth in Lending Act. This is very important. Make sure you read that. The Electronic Funds Transfer Act. So all of those that are bulleted and written in blue, make sure you review these for test purposes. And then you have two more on page 92 as well. If you look on page 92 at figure 419, you can see a sample truth in lending statement as well. And then let's talk about collections. Collections is when you have to collect from the patient. Occasionally you may have to collect from the insurance too. Maybe they're not doing their part, but usually it's the patient. So this is on a delinquent account or a past due account. And this is usually 90 days, and after that we start sending collection letters. And your book says 120. But it's usually 90. Around here I know it's usually 90 days. So make sure you remember 90 days instead of 120. So the delinquent claim cycle advances through aging periods, and you can, another bonus about electronic health records is that you can print off aging reports, one for 30 days, one for 60 days, one for 90 days, one for 120 days, and you can see, maybe there's a certain insurance that's not sending payments back promptly, and then the doctor may decide not to, provide services for those patients with that certain insurance. And a lot of you may have encountered that. All of a sudden your physician is not, taking your insurance anymore, and that's probably what happened, because they weren't getting paid in a timely manner, or they weren't getting reimbursed well. So Table 4.1 lists a lot of reasons of why you should track claims. The first thing is coding errors. Physicians can upcode, and then we can downcode as well. So we could possibly be getting more money for our physician's office or hospital, and we, are downcoding by accident. Unbundling, this is a federal offense. When we have a global procedure like the appendectomy that covers everything, instead of doing just that one appendectomy, we're coding for the appendectomy, the anesthesia, the pre-op, the post-op. That's a big no-no, but unfortunately people get away with it all the time, so watch your explanation of benefit for that. Delinquent account, a denied account, and there's several reasons that we've discussed why it could be denied. Lost, it just wasn't, it fell through the cracks. That happens. Overpayment, the payer may have overpaid, and a lot of times, we won't report it in the office, but again, that's a no-no. We can be fined for that. So if they overpay, what you want to do is you contact the insurance company, and you send, either the whole check back, or you send the portion that they overpaid you back. Payment errors, pending or suspenseful errors, like a fraudulent claim, rejected claims, and these are also called soft denials as well. So if you look on page 94, the best way to deal with delinquent claims is to prevent them, and these are ways you can prevent them. Verifying your plan for all patients, determining their coverage, and I think we've pretty much covered all of these. Make sure you submit a clean claim. Make sure you contact the payer, if you haven't received a payment. Reviewing suspenseful records. Why have you not been paid, or why weren't you paid as much? So review it. And then submitting supporting documentation. If you don't submit that documentation, that's going to slow down the claim process. And then a lot of times after about 90 days, we will outsource. If we haven't got a payment, and we outsource using a collection agency. And we all know about collection agencies. I'm sure everyone's been contacted by one or more nowadays especially. So if you look at figure 420, that kind of shows you an example of an aging report. And I'll try to go over that with you in class, but you can see all the different insurances, and then all the claims and how many days it's been, and how much they owe, who the patient is, etc., etc. Look on page 95. You have a term called bad debt. An account receivable that cannot be collected by the provider or a collection agency is called a bad debt. So to deduct a bad debt, the amount must have been previously included in the provider's income. And unfortunately, bad debts do happen a lot, and it gives you an example under there, so read that. And then you have a purple box at the bottom of page 95. That's a very good thing to review, and it's a 10-step process in handling your collections. And maybe even to prevent collections. Let's see. The last thing I wanted to talk to you about was the state insurance regulators. Basically, if you're having an issue with, one or more insurance carriers, you can report them to the state, and they can be fined to where they're, put out of business even, or they can be fined or face criminal activities as well. So that's where we're going to stop in this chapter, and it was a long lecture, but I just basically touched the important things. So main thing is you need to look over your main terms, look over all those steps and the processes, and know those. And then again, you will have one competency with this, and you'll have to fill out a verification form. And then we'll talk more about this as far as what to look for on testing and your case study exam the next time we meet. So we will stop right there.